Hello, my name is Chris White, and I am one of the hosts for Parks Associates' new podcast, The Connected Consumer. This podcast is all about Parks Associates' data-driven market insights on emerging consumer technology products and services. It features our talented analyst team and industry leaders who are bringing new and innovative products to market. Throughout this podcast, you'll get an inside look at the latest industry trends focused on the connected consumer, home automation and security, energy management, connected health and independent living, and digital content and video services. In this episode, we will chat about the Zigbee Alliance and CHIP, rebranded to CSA and Matter, with guest speaker and our very own researcher, Amanda Kung.
I do have a question from the audience. How do you see working with utilities as a channel to increase smart home adoption?
The panel's perspective, the builder's perspective. Now let's see what the audience was thinking. How big a challenge is interoperability?
Someone submitted a question. What is the take for managed Wi-Fi services?
I'd like to divert from my next question to kind of cut to one of our audience questions. What type of content do you feel most likely to drive MVPD subscription and retention?
We did have a question in from our audience though, so let me jump over here real quick. Have you or are you thinking about solutions around employee privacy?
We have a lot of questions coming in. I kind of want to dovetail on one of them. Can you talk about how you kind of view the pay TV business model?
Just a reminder to our attendees, you are able to ask questions in the live discussion button, which should bring up a panel, and there's a Q&A tab.
If you miss a live session, you can go back at any time to watch on demand. Go to Watch Replays and click on the session that you want to view. Have you created your own event agenda and swap card? Visit the Agenda and Watch Replay tabs to add sessions that interest you to your own event. You can go back to My Event to revisit any bookmarked sessions, sponsors, and items. We want to make sure that you're connecting with our industry-leading sponsors. You can interact with them by visiting the Booths in the Sponsor tab. You can also bookmark sponsors or add items to your event to view later. Sponsors have uploaded extra materials for attendees. Make sure to visit sponsors that interest you to chat with one of their team members or save documents for later. We have dedicated meeting slots set up for break times between sessions. Continue the discussion by requesting meetings from others in the SwapCard platform. Schedule a meeting with another attendee or a sponsor by visiting their page. The panelists and speakers will be addressing your questions live during the stream. During the stream, use the question tab to ask your questions early in the presentation. Go to the poll tab to answer polls that will be discussed during the live stream. If you need help navigating SwapCard, please reach out to our team by mentioning @Parks Associates in the chat box or by contacting one of our team members via our company page. Hello, we're excited to welcome you to Parks Associates' 8th Annual Connected Health Summit, being hosted virtually across 2021 with sessions featuring our esteemed analyst team sharing Parks Associates' latest consumer data and market insights. In its 8th year, Connected Health Summit is an executive conference focused on the impact of connected devices and IoT healthcare solutions on consumers at home. The past 18 months have had an unprecedented impact on healthcare worldwide. The COVID-19 outbreak and resulting public safety measures led to sharp decreases in in-person visits, the delay of many elective procedures, and dramatic changes in how healthcare is accessed by patients and delivered by providers. This year's event, Connected Health Summit, Consumer Engagement and Innovation, addresses opportunities for new solutions including smart home platforms, telehealth services, voice assistants, and wearables to empower consumers, caregivers, and providers with new insight into patient health. Providers must rise to meet the growing demand for services in independent living, chronic care management, remote access to care, and wellness and fitness. New business models, technologies, and solutions are providing a more consumer-centric experience. Telehealth and independent living solutions are extending healthcare and enabling healthcare delivery to a larger market with a specific impact to elderly, patients with chronic conditions, rural households, and caretakers. We look forward to sharing more of our research across the year and bringing you the industry leaders in the connected health industries. Thank you for joining us today for these sessions.
Good afternoon, everyone, or good morning, depending on where you are. Welcome to the Connected Health Summit, our one-day event looking at personalization and connected health, as well as the impact of AI. I'm Kristen Hannock, a senior analyst here at Parks Associates. I lead our connected health research, designing and authoring our research reports, moderating and presenting at our events, and regularly speaking with industry executives to help answer some of the biggest business questions impacting the connected health market today. Before we get started, I'd like to give a special thank you to our sponsors, Alarm.com and Everise, for helping to make this event possible. As well as a thank you to our supporters, CEDIA, Connected Design, DealerScope, SCTE, the Monitoring Association, Z-Wave Alliance, ESA, Health Tech Insider, and mHealth Times. If this is your first time joining us in 2021, welcome. If you were with us for our January or April events, welcome back. As a reminder, for 2021, we are doing a new virtual event series throughout the year, with our upcoming conference days in August, September, and December on a variety of topics across virtual and connected health, independent living, healthcare innovation, and interoperability. In terms of the agenda for today, I'll be kicking things off with a 10-minute presentation sharing some of Parks Associates' research and views on this market. Afterwards, we'll have our visionary insight with Andy Tubman, Chief Clinical Officer of Musical Health Technologies, who will share how his company is combining wearables and AI to measure the impact of music therapy on Alzheimer's patients. Following that, we'll have our executive Q&A with Kristen Valdez, CEO and founder at BeWell Connected Health, and then our panel discussion on the subject of AI and personalization in medicine with a great lineup of speakers. We'll end our day with networking discussions in Zoom. We will be saving time for questions after our visionary insight, executive Q&A, and panel discussion. So if you'd like to ask any of our participants a question, please make sure to submit it in the questions tab to the right of your screen. So yes, over the past year, Parks Associates has kept a close eye on the virtual care space, speaking with some of the top companies. In 2020, we fielded a survey to over 5,000 US broadband households, examining their use and perceptions of virtual care and how those had changed. This year, Parks Associates ran another study of 5,000 US broadband households, examining how things have changed throughout 2021. I'm going to spend the next 10 or so minutes highlighting the research coming out of both years' work, as well as our more recent study. So yes, as we all know, the COVID-19 pandemic changed the healthcare landscape dramatically and permanently. Early in the pandemic, there were lockdowns and state-led rulings that led to a pause in many types of elective care. Some patients avoided care due to the risk of COVID-19 infections. Best practices were for patients to only come in when it was absolutely necessary. This, of course, introduced many problems for the healthcare world. Elective care drives much of the revenue on the practitioner side of things, so people's businesses were threatened. On the patient side, patients were going without care. There was a risk of serious conditions going undiagnosed and untreated, of chronic conditions worsening without guidance. People generally had a difficult time getting the care they needed through traditional channels. With the traditional channels not working, clinicians, patients, and payers turn to non-traditional channels. Technology, remote care visits, remote diagnostics, remote monitoring platforms, and other virtual care modalities. This was an increase in virtual care to an unprecedented extent. Regulators also took notice of this need, making massive changes to the reimbursement and regulatory landscape. Many care providers were reimbursed for remote visits at a similar scale to in-person. The number of conditions people could seek treatment for dramatically widened. Hospitals and care providers jumped to take advantage of this trend, rapidly launching their own platforms using whatever technology they had available. And soon, many consumers could just schedule a visit with their regular physician. Use of connected health devices also skyrocketed, as providers and payers realized they needed biometric data to augment these remote visits and make appropriate care decisions. This all led to a sea change in how technology is perceived and used by care providers and health systems. It is no longer a threat for many. Instead, it has become a valuable tool in their tool chest. And for a time, it was what allowed them to continue doing business without going bankrupt. Companies are now more open and more eager to figure out better ways of doing things, to build new best practices. And it has, in many ways, become a disadvantage to them if they do not offer some type of remote visit or remote patient monitoring program. To illustrate some of this increase in remote visit use, here's a trending chart from one of our studies of 5,000 broadband households, fielded in the second quarter. So I said one study. This is actually 4 different studies beginning in 2017. And notice the dramatic jump from 2019 to 2020, where the percent of households conducting remote visits grew by 170%. Also notice the big bump between 2020 and 2021, where adoption grew by another 56% year over year. As of today, almost 2/3 of US broadband households have done a remote health consultation. This isn't something that healthcare players can afford to ignore anymore, or that they can hope will go away. It's here to stay. I mentioned that we'd seen increased adoption of connected health devices and programs. Here are a few data points that we can share. As of the second quarter of 2021, over half of US broadband households own and use an internet-connected health product or fitness device that captures their biometric data. These include a mix of products purchased at retail, received from employers, from payers, as well as from care providers. When it comes to actual participation in a medical program that uses data gathered from devices at home, that is remote diagnostics, remote patient monitoring, etc., 40% of US broadband households report participating in such a program at least once during their lifetime. When we asked our survey respondents how they felt about sharing device data with clinicians, over 60% had found that at least one of our tested models were appealing, as rated on a 7-point scale. So there's a lot of use of consumer devices. Many consumers have been touched by actual medical devices and programs at least once during their lives, and many more are open to further engagement with these types of programs. Thinking about all of the connected device types and the variety of data they collect, there are many different types of use cases. From the more established use case of remote patient monitoring for chronic conditions or monitoring after discharge from the hospital to diagnostic support for telehealth consultations. Sensors and devices in the home that can proactively monitor and support older loved ones as they age safely and well in their own homes. And the new use case brought on directly by COVID-19 of proactively monitoring one's health and one's family members' health for signs of illness in order to engage in public life, from travel to education to working on site with colleagues and clients. Something that has helped to drive the expanded connected health device market is overall familiarity with telehealth. We measured respondents' familiarity with remote health consultations on a 7-point scale, and also asked them how important it was for telehealth services to be able to remotely diagnose or monitor health conditions by the use of devices on another 7-point scale. As we can see here, there is a strong correlation, very strong linear correlation between familiarity with telehealth and wanting the benefits that connected health devices bring in terms of remote diagnostics and remote monitoring. In general, consumer familiarity with telehealth matches use. Around 2/3 of US broadband households consider themselves to be familiar as rated on a 7-point scale. About 80% of self-reported telehealth users fall into this bucket, and around 40% of non-users can consider themselves familiar. However, and this might be a challenge, familiarity hasn't measurably increased since we measured it last year. So as much as remote consultations, remote diagnostics, and remote patient monitoring has grown, more can certainly stand to be done to get patients aware and familiar and on board. So I've discussed some of the trends around remote health consultations, remote diagnostics, and remote patient monitoring. Looking at the overall landscape for health tech, there are, of course, many, many more applications and use cases. Some of what we'll be talking about later today will involve some of these use cases, such as software as a medical device, decision support and triage tools, patient assessment tools, risk identification and patient population stratification, automated care platforms, clinician workflow management, as well as others. I believe before we head into our next discussion, we have just the time to take one question. It looks like I have a question in from the audience now, asking, one of the main barriers to telehealth adoption were state laws, yet in COVID-19 there was rapid adoption. Do you know how these state laws were handled to allow such fast adoption? The answer is yes. In many cases, the states had temporary waivers that were enacted to allow for clinicians and patients to be able to conduct telehealth visits. These waivers were extended to the end of the pandemic emergency, so they are still ongoing in many cases. There is some uncertainty around whether or not they will remain permanently available, but there are very promising signs from CMS and the payers that this is, in fact, a permanent change. So yes, moving on. Speaking of new use cases, it is my pleasure to introduce our visionary insight for this event, Andy Tubman of Musical Health Technologies. Mr. Tubman is a board-certified music therapist with over 20 years of experience. In 2005, Andy founded Integrative Music Therapy Services, which provides music therapists for healthcare facilities, drug and alcohol centers, and state-funded regional centers and individual clients throughout Southern California. Andy's work has been recognized by the state of California as providing essential care for the severely disabled. And Andy, feel free to take it from here.
Okay, hopefully you can hear me all right, and I'm going to share my screen with you now. Yeah, you can hear me all right?
Yes, we can hear you great. I don't think are we seeing your screen yet?
It is on the monitoring screen, but.
Yes, we see it, but it's not full screen yet.
Okay, I got you. Hold on. All right. How about now? We're good?
Yes, looks great.
All right, brilliant. Thank you. Okay, so thank you so much for Parks Associates and everybody to have me come and speak on the intersection of technology and music. I do get to speak often on the intersection of music and the brain, but this has stretched me a little bit. Not that my company is not involved in a lot of tech, but I really had to kind of clarify my thoughts and what we're really doing in terms of machine learning for this presentation. So I actually appreciate the invite, not just to be included, but also to kind of get me to work a little bit. And so I wanted to start by just saying that I've been a music therapist, so clinical work, right? Not on the business side, not on the technology side. For 20 years, I started in traumatic brain injury rehab in Philadelphia, and then worked my way across the country, basically, in Nashville for about 5 or 6 years in inpatient psych, adult and geriatric, and some children. And then when I came to Los Angeles, I did a bit more psych, but also had the opportunity to start a private practice with folks with neurological challenges, and had a thriving practice there. But the challenge was actually that we had a waiting list, and we decided to, look at some different ways to scale, and came up with, a couple different solutions so that we could get out some of my skill set, but also just ways for non-music therapists to use music effectively. And so we created Musical Health Technologies, or SingFit, which is our product, and really got that out the door. To really get therapeutic music used by many different populations, hopefully, and that's what we're working on. So we will touch on that today. We're going to give a little bit of background around the science of singing, which is significant in what we're talking about, so you understand how it relates to data collection and machine learning. I'm gonna show you a little video of our product, but also how powerful a musical experience can be for many parties, even within one person singing at the house. I will give you a quick review of what our company is up to and the offerings that we have right now, and then I will also go into the bulk of things, which is the technology. I like to call it the machine learning and the data-driven solutions. We'll then look at some outcomes overall of how the music solutions and machine learning can affect outcomes in general, and then summarize things with what the vision of the present and future is, because we are in the future, my friends. Yes. All right. So first of all, over the last 15, 20 years, the neurologists have really dove into the music therapy space, and with the invent and the access really to fMRIs, the real-time pictures of the brain, they're able to map the electro exchange in the brain and what's going on when doing what. And so what they found is that when you are singing, that you are integrating language centers, timing centers, motor centers, planning centers, subcortical, topical, short-term, long-term. The brain is lit up like the Vegas Strip, singing. So the other things that folks have found is that, I'm going to move my slides here. Yes. The other things is that as it's working as a global, right, a global stimulant, basically connecting parts of the brain globally, especially with language, like I'm saying with singing, people are able to start rerouting damaged portions of the brain. So Gottfried Schlag at Harvard brought somebody from nonverbal to verbal, right, using melodic intonation therapies, which is vocal and rhythmic protocols. Gabriella Giffords, who got shot in the head, Congresswoman Giffords, got shot in the head. The first thing they do is assign a music therapist to start getting her in her singing Tom Petty, and really exercising her brain globally to not just build new neural networks, but also specifically to working on speech along with our speech therapy team, right? So there's a lot of really interesting research that the neurologists have done in terms of what's really working for the brain and working in the brain while singing and actively making music. Some of the other research that the neurologists have looked at is the chemical release. We all understand that music and singing can make us feel better. This is, normally thought of as, the endorphin release. But what we've also shown now is that it's not just endorphins, it's serotonin, it's dopamine release. It's also a regulation of cortisol. And cortisol is our stress hormone. And so just think about it like this. When you're working with folks with dementia and you have a predictable agitation at 3:30 or 4 o'clock in the afternoon, also known as sundowners. But if you have this predictable agitation and you get people singing at 2 o'clock, then you're regulating the cortisol and softening these negative behavioral expressions at 4 o'clock. And this can work pretty effectively as a non-pharmacological intervention. So the cortisol regulation, oxytocin, this connection chemical, is released when you are singing, right? A lot of really great benefits. And if you're interested in any of the clinical research, I'm happy to send you some summaries or, the full papers if you would like. But great research going on now in terms of the respiratory benefits, especially when you're thinking about COVID and all the respiratory challenges that have come to the surface because of that. And that singing has been shown to, one, decrease the anxiety around taking your next breath, right? So reduction of anxiety. And then it becomes the exercise that actually works the musculature and the respiratory system within that whole process. So a lot of really interesting benefits there. In terms of immunity, another currently relevant benefit is that when you are singing, your immunoglobulin A, hormone in our blood that indicates how strong immunity fortitude, how strong your immune system is. This is increased anywhere from 180 to 240%, says the research, at when you're singing. And then there's after effect if you do it continually. So you can really help to build your immune system. And then, of course, there's our oxytocin release and the socialization that people feel connected when you're doing music in general and when you're singing. So that was a lot. If you have any questions later, let me know. But, there's a lot of really a big body of research that is out there now and that is continuing to grow. One other thing that I want you to understand in terms of music, and then we'll start moving into the data, the technology world after the video, is the difference between passive and active music making. So the passive, typically thought of as a listening experience, can be an extremely powerful tool, right? And how many people out there are actually medicating with music in some way, right? You're putting something on in the background for mood. You're putting your rocker tune on as you're getting ready to go out on a Friday night, right? You're putting optimization music on for the gym. So there's a lot of ways to use passive music and listening. However, when you're listening to music, typically, and passively listening to music, typically you are lighting up, says the neurologist, small and specific parts of the brain, right? However, as soon as you go to the active music making, the drumming, the guitar playing in a band, the singing specifically, right? I'm biased towards the singing, but all active music making is beautiful. This active process starts to work globally on the brain because you're doing the creating. You're not in the perceiving mode. You are doing the creating and utilizing multiple parts of the brain. So this, if you think about the active process, think about it like a yoga practice, right? In that you are engaging your respiratory, your nervous systems, your neurological systems. All of these things are starting to be organized and work together. And so there are times when a passive experience is very effective, like in end-of-life care or in a sensory integration exercise by OTs, right? There's different way in health to use passive, listening as a very powerful tool. However, it's challenging to implement on a mass scale and get consistent outcomes because it relies on the expertise of the facilitator. However, when you are talking about the active music making, it relies less on the facilitator and more on the doing, right? As Yoda would say. Like, it is more about the yoga practice of singing and active music making in terms of neurologically. So I wanted to show you a video for a minute or two, and this is using SingFit. I want to give you a little heads up that Olivia is actually wheelchair bound. She's had dementia for 10 years, and she has not sung in over 10 years. She used to be a singer, right? So she used to be a singer, but she hadn't sung in over 10 years. And this is her first 2 sessions. And one thing I want you to be aware of is that we're not really seeing any technology. And I want to talk about that in a second. But if we can go ahead and play that video, that would be super. Please listen for the lyric coach. That was part of our special sauce that will give Olivia the words so she knows what to sing. One more time.
And soon I'll hear old winter song. But I miss you most of all. My darling. When autumn leaves start to fall.
It's awfully hard to tell somebody what I experienced.
Yes.
Because it was like a miracle.
And so the miracle that you're saying you experienced was what?
My voice returned.
Ah. All right. So, Kristen, if you would just keep me on in terms of time, because if I start rambling, it's not good. And so what we're seeing here is think about the implications of what we're looking at. One, the technology is virtually invisible, right? And when it's voice activated, it's even more invisible. So that, the caregiver can assist or not. The caregiver is trained in how to facilitate and bring out the voice of the client. And to bring out this voice, you are engaging respiratory, the client's insistence on standing, so muscle exercise, strengthening, balance. Her energy levels went up. Her husband said that she didn't need to take naps, right? Her all different kinds. Her cognition goes up after she's singing this, engaged in this kind of singing. So this is a dramatic example, but now start thinking about that in terms of technology and how all those kinds of biometrics and things are relating to data. The way that we have created the singing process to be easy for everybody and a non-academic process, right, for people with cognitive decline. Because when you're starting to read lyrics, right, the whole karaoke thing, it becomes an academic process. But now there's a lyric coach that is the spoken word before you need to sing them. There's the guide singer, there's the music, and then there's a record track that with headphones, Jane in Omaha can send happy birthday to her grandson. She hears the lyric coach and the guide singer in the headphones. She sings happy birthday with the kid's name. And then the app, once it's finished, mixes out the lyric coach and the guide singer and then asks Jane And the caregiver, if they would like to email, Facebook, or Twitter it across the country, the whole thing takes 5 minutes to the grandson. Okay, and so what we are doing in terms of SingFit, which is our company, is we take the technology, the core app, and we point it at different conditions. And so then once we have that, then we have what we call a song printed database. And this has a variety of criteria, a variety of variety of metrics that we pull from to then prescribe the right type of songs for the right type of condition or population. And then through that, we then design training and protocols from very little bit to a considerable amount, designed to facilitate different types of group, one-on-one, solo, or on-demand processes. Okay, so we have a variety of products, and I'll go through and review those right now. One of our main, products with the most traction is called SingFit Prime. That's our group process. That's in over 500 senior care communities nationwide. That is being utilized on a daily basis. This is a product that has themed playlists using our core technology and music, but themed playlists. We have a storyline, trivia, movements, self-disclosure questions, and it's really a session plan that each facilitator who gets trained in needs to get certified in it, and then is able to run these groups in a very specific way, but gets very specific engagement levels and outcomes. Then we have Prime Time, which is a video series that we created because of COVID that is, often published in the communities through Apple TV. And we are starting to release that and getting a sense of the value of what that can do, which is basically a program of, with trivia, movement, and singing that work people through an exercise, a 30-40 minute exercise. We just are releasing now SingFit Studio Pro and Caregiver, and Pro is designed for SLPs and OTs and how to utilize that in their practice. And then Caregiver is for paid and non-paid caregivers, love economy caregivers in the house that are utilizing singing for everything from quality of life to mood elevation to positive shared experiences. And then we're also working eventually on a solo process. Now, so with our Studio Pro that is very fresh right now, what we have found is that a one-on-one singing process integrated into a speech and language pathology session has a lot of different kinds of benefits. But one of the main benefits is that they can show increased engagement and increased progress. And what that ends up being is their ability to increase how many sessions they can bill for, right? So that's where things are going with our speech and language therapists, as well as looking at a variety of different kinds of metrics that they're collecting for us in terms of language development and using singing for specific language development, for specific goals in language development is what I'm saying. Okay, so I'm going to integrate what we just talked about with the speech therapist into the technology in a second, but I want to give you a scenario that we've been working on that has not been tested yet, but that is coming, and that is the idea of the wearable. So an accelerometer is you can see my awful graphics, the blue watch on the gentleman who's angry. But the accelerometer, in theory, should be able to really figure out how much movement has occurred, right? So when agitation goes up for sundowners, as we talked about earlier in the afternoon for someone with dementia, the accelerometer is going to read this, and it's going to start trending this, and they're going to see that at 4 o'clock, the accelerometer is going to read that there's more movement, therefore more agitation on a daily basis. Well, then the machine learning element to the, in the future, SingFit accelerometer solution, the machine learning says, Mr. Johnson, it's 2 o'clock. It's time to sing your rock and roll favorites. So then on the speakers in the room comes, and Mr. Johnson's like, rock and roll, rock and roll. And so on the speakers comes the songs, his favorite songs that have already been sorted out, and the appropriate ones for him, right, that have already been machine learned and sorted out prior. And he does his playlist, and he regulates his cortisol, and he elevates his mood, right? And then you will see in the trending from the accelerometer that the movements around 4 o'clock after a month or two of singing has reduced, right? And so then you can look at a week's trend, you can look at a couple months, you could look at 6 months or 2 years, and really start to see how a singing experience combined with machine learning is going to really show how to increase quality of care, but facilitated by the technology. For the most part, there might be some hands-on that's needed, but by the technology. I wanted to give you just an example of the type of data points that we collect now for our song printing. And what we have learned is that for, again, folks with dementia, that if you give them a certain number of syllables in a cued phrase, right? So if you remember back to the video where it said, climb every mountain, right? So there's a cue. That cue, climb every mountain, 5 syllables, fly me to the moon, 5 syllables. These 5 syllables, 5 to 8, but no more, folks with dementia are able to integrate into a musical process and spit it back out and sing it out, right? And then perform it. So if you go to 10 to 12 syllables, you're going to get some deer in the headlights. Your engagement is going to go down, and your performance success is going to go down. And so these number of syllables is one of the things that we track in terms of how to song print, what to song print, and then how to basically how to prescribe the specific songs to the specific individuals and their functionality and their conditions, if you understand what I'm saying. So this is just one example of the kind of data that we are aware of, that we integrate and collect. A few more examples that we are working on are, voice analytics, because the tool has a recording element to it. There's all kinds of things that folks can do with, recorded voice these days, and especially recorded voice that is being challenged by different kinds of songs. And so there's voice analytics that we're going into. There's using voice as a diagnostic tool, so early intervention of Parkinson's and different things like that, that we're starting to look at. And then obviously the whole biometric movement in terms of collecting data. When you're singing, your biometrics are affected in a variety of ways, from galvanic skin response to heart rate to to a whole bunch of things. And so the singing and the musical process really works as a great engagement tool to initiate and to collect a lot of these biometrics that can be so valuable. I know I'm going quickly here, but I imagine I am running close on time. I don't know. Yeah, what do you think, Kristen? How are we doing?
We have a few more minutes, so I guess it depends on whether or not you want to keep going or maybe stop and answer a couple of the questions we have from the audience.
I have two more slides, so let me just get through these, and then we can kind of have a little discussion. Does that sound all right?
That sounds great.
All right. And so what's happening now is that we are really coming to a place where we're starting to see how to use music to effectively create consistent outcomes. And it is a lot more than, isn't it cute that grandma loves Frank Sinatra and she lights up, right? Because when someone tells me this, that means that grandma has some sort of connection to that song, right? There's some connection there. And literally on a cellular level, her mitochondria is getting excited. And there's this light up. My question is, what do you do with it, right? How do you utilize this light up in terms of the musical process, in terms of the data and the machine learning, and then the clinical outcomes and how they are going to be affected, right? And so there is a lot of really interesting outcomes that are showing now that you are able to reduce agitation in dementia. You're able to reduce depression with folks that have severe depression, especially if you can get them singing and making music on a regular basis. There's really great research and outcomes around the respiratory, even to the point of stimulating the lung tissue, and some of the most recent research is looking at how it's regenerating some of this tissue. The singing process, I believe it's probably from the vibration side of things is what's stimulating, but that's a hypothesis. Even working with reduction of blood pressure, and what was the other one? The variation. What is the heart rate variation? Right, really positive effects with the singing process, heart rate variation. All of these things, my friend, rely on the singing on a regular basis, right? If you do it once, it's called entertainment. If you sing daily or 2 to 3 times a week, and you're really actually getting that respiratory system engaged, then you're really talking about a healthcare tool that's mobile, engaging the person in their own health, and then facilitating this data collection. My last slide is a little bit confusing, but I had to throw the spoon in here. I don't know if you can see the bad graphic with the musical notes in the spoon, because we like to say that SingFit and that the singing process is the spoonful of sugar and the medicine, right? So what is coming in the future, and what is, I believe, visionary about what we're talking about, is that the music is both as therapy and in therapy. So it is the engagement tool, right? Because it's Sinatra, it's Patsy Cline, it's Willie Nelson, it's Queen, it's whatever your musical preferences would be, that are pulling you in to this process that is engaging you in your health, right? It is the spoon. It is the gateway to exercise. When we talk to companies about, companies that are working on respiratory rehab, they want people to engage in exercise. And the singing process is the gateway to that process as well. So it is the engagement tool, the spoon, as well as the medicine itself, right? And this is the advantage that a musical process has over many other kinds of more mechanical processes in healthcare. So we have our tech. The machine learning overall is going to assess both, everything from age to clinical goals to preferences. And then we will be able to say this person is too fragile for a tech-driven prescription. They need to go to a professional. They need to go to a music therapist or a speech therapist, what have you. But there's going to be a majority of people that are going to be able to continue into the technology programming, and we're going to be able to prescribe through the music, through the machine learning and the musical process, how they can use music to better their health and increase the quality of life, reduce the amount of money that the healthcare world is spending, reduce the amount of medications that they're needing to take. I know these are big claims, but in the future, I think this is where it is going, how to really enable self-healing. So maybe we could do a couple questions. I hope that was all right on time.
Sure, and I think we're a little bit over on time. We do have time for one question as long as we keep it kind of brief.
Sorry, okay.
That's all right. A lot to cover.
Yeah.
So we have a few questions in from the audience on a similar vein, so I'm just going to combine them. We have audience members interested in whether or not you have evaluated music therapy for a few different use cases. So for example, maybe memory-based trauma, PTSD, dissociative identity disorder, or even something like blood pressure. Is that something you've looked at?
Yeah, so three things. Let me answer all three things. First of all, this is not music therapy. I'm a music therapist, but what SingFit, what we're talking about here is, I define that as therapeutic music, right? Because to be music therapy, a music therapist needs to be involved in or giving the diagnosis and then creating outcomes. So it's just semantics. But in terms of something like PTSD, is that music therapists are working one-on-one in this, and they have been for a while. When it comes to this, to me, one has to be very careful ethically. But a singing process can be extremely helpful with PTSD in opening, emotionally and confidence and stimulating neurologically in different ways. But again, like I said at the last slide, there has to be an assessment process in terms of the fragility of the person, right? And where they are in that trauma journey, right? Because you can't just say, here's an app, go ahead, let's see what happens. Right? That's a very serious kind of, on my fragility scale, like PTSD, depending on the situation, can be extremely to the left and on the fragile side. So one just needs to be careful about when you are, assigning and thinking about these things, how to do so very ethically and making sure that the outcomes are going to be thoughtful and sensitive.
Yes, thank you so much, Andy, for this wonderful keynote and for answering our questions.
Yes, thank you so much for having me. I appreciate it.
Yes, and then we are going to transition to our next upcoming session, so our executive spotlight with Kristen Valdez on Be Well Connected Health. Thank you all so much.
I do have a question from the audience. How do you see working with utilities as a channel to increase smart home adoption?
The panel's perspective, the builder's perspective. Now let's see what the audience was thinking. How big a challenge is interoperability?
Someone submitted a question. What is the take for managed Wi-Fi services?
I'd like to divert from my next question to kind of cut to one of our audience questions. What type of content do you feel most likely to drive VMVPD subscription and retention?
We did have a question in from our audience though, so let me jump over here real quick. Have you or are you thinking about solutions around employee privacy?
We have a lot of questions coming in. I kind of want to dovetail on one of them. Can you talk about how you kind of view the pay TV business model?
Just a reminder to our attendees, you are able to ask questions in the live discussion button, which should bring up a panel, and there's a Q&A tab. Okay, great. Thanks, Kristen and Andy, for that really pretty incredible and touching opening session and keynote about therapeutic music, and really interesting to see how that is going to progress in the future with some of the more future-looking evolutions of that type of service that you talked about. Next, I'm so pleased to welcome Kristen Valdez to this executive Q&A chat. Kristen is the founder and CEO of Be Well Connected Health. She's dedicated her career to empowering consumers with the data and tools they need to take control of their healthcare journey. She was recognized in 2020 as one of 4 women transforming industries by Accenture and Springboard Enterprises for really reimagining how we can more efficiently and wisely leverage technology to access healthcare. And prior to founding Be Well, Kristen was an executive at United Healthcare running Medicare Advantage plans across 12 states. So very excited to welcome Kristen in and to learn from your background and experience about this topic today.
Oh, well, thanks so much for having me. It's great to be here.
Awesome. Well, what I'd really love to do is to start by, many of our audience members may be very well aware of Be Well and what you do, but I'd love to just set the stage for those who might be hearing about your solution for the first time. So can you tell us a little bit about Be Well Connected Health and how you fit into the larger connected health ecosystem?
Yeah, absolutely. Be Well is a digital transformation platform. We are designed for consumerism in healthcare. So while our ultimate end user is a consumer of health, we are a B2B business that works with health systems, insurance companies, retail pharmacies, and self-funded employers to provide the populations that they serve with a reimagined experience from a healthcare perspective. From the consumer side, which is really the sexy side of what we do, we give consumers exactly what they're looking for from healthcare, which really boils down to 2 things. 1 is be there for me when I need you, and 2 is tell me when there's something that I need to do. And our platform was designed completely around research for patients, caregivers, care partners, and general consumers alike, where what consumers ultimately want and that Be Well empowers them with is 1, access to all of their health information in one place. Be Well is one of the largest trusted third-party applications in the country, where we use the HIPAA patient right of access to help consumers to collect and aggregate all their health data from their payers, their providers, their wearables and sensors and smart homes, their pharmacies, their labs. All of that data comes in. And I should say we're also one of the first trusted third parties live connected into fee-for-service Medicare and the Veterans Administration as well, with the goal of giving consumers a 360-degree view of all their health data in one place. But in addition to making that data consumable, creating longitudinal trend lines, wrapping useful information and education around that data so that consumers can really start to understand what their healthcare data shows and what it means, we then have created a gamification platform designed to be proactive in health. So we've codified evidence-based medicine guidelines and prevention and screening guidelines to help consumers know when it's time for them to do something. As an example, when was the last time that you received a phone call or a text message saying, hey, happy birthday, it's time for that preventative colorectal cancer screening? Now, nobody really wants that message on their birthday, so we don't do that. But it is important to help consumers know when it's time for them to do something versus wait for them to go into a doctor's appointment when they have an acute issue and then ask, hey, when was the last time you had your tetanus? Or when was the last time you had your labs drawn for your A1C? So helping them to be proactive and then finally navigating them to care. We're big believers that healthcare is going to start to be consumed the way that you would water from a vending machine, virtually, in person, digitally, and asynchronously. And so we create those easy pathways for consumers to find and access the right level of care when they have a need.
So you've talked about a really incredible variety of data sources that you're pulling in, and I really want to get into that in just a minute. But before we go there, really everybody who's worked across the health ecosystem this year has really been, tested and pushed and changed by the circumstances of the past year. I was wondering if you could share some quick perspective on what that looked like from Be Well's perspective and how you've adapted over the past year.
Yeah, we had to adapt pretty rapidly to our customers' needs. And as I share, we have a variety of customers. So on the employer side, employers closed their offices, the people were working from home, but we also have a number of essential personnel. So we have folks who work at banks and work at hospitals and provider organizations. And so it was very important for us to very quickly adapt to things like, one, let's help people get to the CDC symptom and triage list to determine whether or not they need to be tested or could potentially have been exposed to COVID. We then had safe return to work. As you know, it would be very catastrophic for a nurse to go into a hospital on shift and be spreading COVID. And so we had to have attestations that folks had not been symptomatic, that they had not been exposed, or that they had been tested in a reasonable amount of time. And then we would help our employers to help their employees know when and what the instructions were to go back in to do a safe check-in into work. We also have health systems as customers. So you can imagine that health systems were very quickly asked to adapt to figure out how are we going to triage and help manage the vaccination efforts when vaccines came out. So helping our health systems to create robust tools where people could pre-register, and then we would simply let them know from a convenience standpoint when they were eligible for the vaccine, what locations they could be seen at, helping them to mobile and digitally schedule their appointments, and then navigating them from a direction standpoint, including reminders of when their vaccine is, and then giving them access to their vaccine card electronically so that they would know which vaccine they received and what date, and then when their return appointments were with reminders. So we were tested, I would say, pretty heavily throughout the COVID year, and we're right at the center of helping our customers to adapt as quickly as they needed to for the COVID situation.
And so this past year is almost testing and fire for sure, but of how to incorporate new lines of information and data when you need it. And that's sort of emblematic of how the connected health space has really evolved. There's new technologies, new connected health devices, new lines of information that seems like are coming online that you need to integrate, just about every month. So let's talk about, the data. So the core value proposition and purpose of Be Well is to integrate an incredible variety of disparate information sources to empower the consumer and their family members, right? With this integrated view of their healthcare and link these pieces. How do you do that, right? Can you talk us a little bit through how you actually integrate all of this data into one place?
Yeah, data is really broken down into access and then integration. And when you think about access, the new rules from CMS and ONC, information blocking and interoperability, are really what I like to call the sentinel event that changed healthcare forever that no one saw coming. Because ultimately, it puts the power and the control in the hands of the consumer, where they have the right to draw their data down from any data holder. And they also have the right then to direct it to anyone that they choose. So you can imagine a world where somebody might be moving across state, have one provider, want to take their medical records and then push them to a new provider where they've just moved and relocated. And those things from a technology perspective are certainly now possible. And so when we think about how we integrate data, most healthcare data does still not transact in what we call smart on fire, or the format by which we believe all healthcare data will be transported into the future. So today, we will get everything from electronic data interchanges to SFTP file drops and CSV files, all the way down to Excel spreadsheets sometimes from our employers. But we've taken the approach of being fire first and really leaning in. So all of the data that we collect from our partners, no matter how we receive it, we map and correlate into FHIR, into API standards, so that our data is cleansed, it's longitudinal, it's clean, and it has the ability through an open API to then interface with any partner that our customer may have. Because as you can imagine, the world of digital health is accelerating at a massive rate and pace, and that there are digital health solutions for virtually, all clinical conditions, and there's multiple competitors. And so having the ability to have APIs from a consumer perspective, where a consumer can say, hey, you know what, my biggest challenge with my health is really my sleep. And then having solution providers that they can push their data to without having to fill out another form or another registration, and be able to push their data to whomever they feel can add the most value in their healthcare experience. So I would say we integrate data very carefully. We prefer APIs. There's a lot of API-driven systems, especially in the devices and the connected health space. But a lot of times, legacy healthcare data, whether it's medical claims or electronic medical records and others, in some cases are still, especially in bulk, not available through the FHIR standard. So we have made everything FHIR native and API accessible for our integrations.
Got it. I mean, you're really doing all of that work, that really hard work to get them into the format that they need to be in. So can we talk a little bit then about the application of AI and machine learning to this data and how BeWell might be doing that today, or developing tools to do that, to really generate new insights on this vast array of data that you're seeing. And to your point, you're serving multiple people, right? There's maybe insights for the consumer, for the provider, for the payer, for employers, because there's the employee wellness program. So, are you using AI in different ways for those people or for different technology stacks? Talk us through that.
Yeah, absolutely. We bucket AI and machine learning into a couple of different categories. So one is data cleansing. For anybody who's been involved in healthcare data, you know that it is sometimes the most difficult and complex data set to deal with. And so because we're merging data from so many sources on an individual, identity is particularly important. We need to know that if Kristen Valdez in one system has maybe had her name spelled wrong in another system, that is in fact the same individual and human being. And so AI has a real opportunity to, and data science in general has an opportunity to help identify when there's enough properties around an individual that it is likely the same human being. And that's particularly important when you're giving consumers access to a comprehensive record. We also think about how to find appropriate care. And so when you think from a consumer perspective, if they're going in and trying to find a doctor, right? Consumers typically come into the healthcare delivery system with a symptom. I have a headache. They may not know that they need a neurologist for persistent migraines. In fact, they may not even know how to spell neurology. And so oftentimes in the healthcare system, there's frustration on both sides because consumers are having a hard time navigating to the right kind of doctor that they need to help solve their problem. But at the same time, providers are very frustrated because sometimes consumers will make appointments and they're not the right fit for that doctor or what they're trying to achieve. As an example, some physicians may be surgical, and if you're not a surgical candidate, then that leaves money on the table for those surgeons if you really needed a different kind of doctor. But also the right level of care for those symptoms. Is this something that needs to happen in an emergency room versus in an urgent care setting versus in a clinic versus primary care? And helping consumers to navigate and find the right option for them and based on their preferences, which is the new part. So when we know that consumers are more likely, digitized, will they find physicians that more likely will text message with them or see them virtually or asynchronously? And so matching of consumers to their physicians is another great use case. And of course, there's so many others that we're working on, like how consumers choose their insurance plan, gold, silver, platinum, which one is actually the best one. Most consumers today will, if they're healthy, choose the lowest dollar premium. And if they're expecting surgeries or high medical expenses, then they're going to choose the platinum plans, when the reality is that it may be the silver in the middle that works for both. So really working to help consumers understand how they perform on various plans and then to select the right plan moving forward.
And I think I also saw some part of your tool that also has pricing and pharmacy and medication comparison, right? And empowering consumers to understand the pricing of medications and, how to navigate that as well.
Yeah, we make things really difficult. So let's just imagine a consumer that has multiple comorbidities, is taking maybe 11 medications a day. So when they go into various specialties and doctors who are prescribing scripts, they're coming from more than one provider. And so oftentimes they don't have the opportunity every 30 days or whenever their renewal is 90 days or even through mail order to know, is there a different medication even within my, formulary that is more affordable for me based on my insurance plan? Or is there a pharmacy? Most consumers don't know that their prices can differ pharmacy to pharmacy. Is there one that's more affordable for me? And or is it more beneficial for me to use my cash price or pay cash than it is for me to use my benefit? And so there's a great concept called real-time pharmacy benefit check that now allows consumers the ability to log in and see at the point of care, oh, you're prescribing me this medication, where should I have my script filled? How much is it going to cost? Should I pay cash? And then behind the scenes, because BeWell is connected to the family's medical data and has the pricing information behind the scenes, we can simply push a notification to a consumer that says, hey, did you know you could save $50 this month by switching from CVS to Walgreens? It's 0.2 miles from your home. Would you like us to transfer those scripts? And so there's great programs through APIs now and through data sharing where we can simply create an easy button for consumers to something that historically they've not only known that they had the ability to do to save money out of pocket, but they certainly didn't know how to do that by having to combine looking at their benefits and their PBMs and understanding brand and generic conversations with their doctors and choosing the right pharmacy and whether cash or benefits should be used. So there's a lot of great opportunities for consumer improvement and creating that easy button that consumers want by creating all the connections and connectivity on the back end.
Mm-hmm. So let's talk a little bit about connected health devices, right? So over the past year, obviously this huge push of telehealth and connecting the facility to the home by necessity. It's accelerated all sorts of technology plans and investment, right, and in remote care. I think it's become pretty clear over the past year that one of the missing pieces of that telehealth experience, if you're just having a virtual chat, is you don't have access to the type of data that you need for certain diagnoses, right? And so there's a lot of focus on remote patient monitoring, hospital at home, and getting the devices and diagnostic and monitoring data needed from a variety of devices, and certainly a big trend going forward. That being said, incorporating connected health device data well into a larger care plan is not something that a lot of health systems, providers, and payers are really set up well to do. Complicated by the fact that there are two very different kind of groups of health devices, right? You've got the sort of regulated medical health devices and the consumer, direct-to-consumer type devices that might be a wearable or a connected weight monitor, blood pressure cuff, they have acquired. And I see these potentially developing along their own paths. Can you talk a little bit about what you see from your point in the ecosystem of where we're going with capturing health device data and incorporating it back into the consumer's whole view of what's happening in their health?
Yeah, absolutely. And so I think we are right at the beginning phases of how we think about monitoring patients and consumers in the home. You're right, there are two classes. There are the consumer wearables, right, like the Apple Watch and Health Kit versus things that you can buy off the shelf, the propellers of the world for asthma and others, the Oura Ring for sleep. So there's a lot of opportunity for those. What we see is that one, in terms of a general theme, keep in mind that healthcare stakeholders have arguably been very behind from a technology perspective with, full on-prem servers and installations, having their data in relational databases. And we saw with the implementation of information blocking and interoperability that a lot of these organizations have had to move to cloud-based data storage in order to create API infrastructure to share data out, even from their own environments. So as you can imagine, the idea of streamed data that can push information per second per patient into an environment that you have is something that has certainly not been thought through. And I can tell you that the majority of physicians that we've spoken with, they don't want to receive the vast amount of data that comes off of the Apple Health Kit every minute or 5 minutes. It's a massive amount of data. And what they would really prefer is insights. So what we see on the consumer wearable side is that most providers, are not opposed to people using and learning about their health. We saw that, even in the early days of, the Fitbit wears, that a lot of times consumers would wear these devices for a period of time and then they would stop. And no one really understood why they would stop until they started asking consumers. And it's like, well, I've worn it long enough to know whether or not I'm going to hit my 10,000 steps in a day or I'm not. I don't need to wear that for it to tell me whether I'm doing well or I'm not. And so I think wearables will become an absolute, part of our lives. People are going to change what they wear. They might have been a Fitbit, then they move to an Apple Watch, then maybe to glasses that can stream and detect pressures in the eyes and other types of things. There's so many opportunities. But right now we're seeing that the physicians really want consumers to use those for their own knowledge and education about their bodies and their lifestyles and their habits. Where the other side of the coin on remote patient monitoring is becoming more important because of COVID. As you know, many health systems lost the ability to track their chronic patients, and they certainly couldn't afford to have those chronic patients who were maybe immune suppressed coming into the health system when they were bombarded and inundated with COVID, which of course would have been very detrimental pre-vaccine to anybody with those chronic conditions. So the remote patient monitoring movement has moved, I would say, forward at a much faster pace with hospital systems trying to figure out and build hospital at home models. Mm-hmm. And they're looking at things like diabetes and cardiovascular, as well as other types of solutions where Bluetooth enabled devices can push. But again, physicians are not interested in receiving all of the data. They're really interested in receiving the insights. So we're seeing a lot of remote patient monitoring tools that are not just streaming data, but now they're layering on offerings to simply provide options to the provider to say, hey, I only really want to know if Kristen's blood pressure reaches X, or if her A1C, or if her sugars reach, or her glucose reaches Y, or if her CPAP is showing that she's not receiving enough oxygen during the night. And so in that case, it's more about alerting and appropriate alerting versus mass amounts of data trying to be pushed into the point of care, into the EMR, which really it wasn't designed for and is not helpful to the providers overall.
Thank you for that perspective. Really interesting. We do have some questions from the audience. So I want to make sure that we get to that. There's two questions that have come in that are actually somewhat related, so I'm going to kind of pose them together. So one is what is the biggest challenge in getting consumers engaged? How do you capture consumers? What is the trigger that happens for consumers to want to engage in this type of solution? And then once they're engaged, is there evidence that being engaged with the tools like yours and having all of this information at their fingertips betters compliance with their care plan or their medication regime, for instance?
Yeah, absolutely. So I wish that there was one answer to how do you engage consumers. And I think if anybody can answer that succinctly with one pathway, then I think they win. And so what we've certainly learned is that, having the benefit of being a healthcare executive for the last 2 decades, it's a problem that we've been studying for a very long time. Historically, from a health perspective, many organizations would look at, medical claim data, which was largely thought to be the most comprehensive set of data on an individual. And they would look at gaps in care, and they would basically segment populations into who was expensive and who was inexpensive, who was high risk, rising risk, or, healthy, who were people in wealthy areas where they had high access to care, were they in food deserts where they lacked basic social components. And so we really broke down beneficiaries into different segments of health status. What we know now, especially from a digital and mobile perspective, is that it's really about digital personas. Is there someone who is a caregiver first, meaning that they caregive to their parents, their spouse, their children, and that you're not going to get them to engage within their own health until they've seen the full picture and feel that everyone they caregive for is under control? Are they gamers? Are they people who want loyalty programs and free things in order to comply with their care plans? You've seen CMS actually now with the AKS Safe Harbors rule empower providers and health systems to, for the first time, create monetary incentives to align to a care plan. So those loyalty programs can now be brought not just from the employer side, but also from the provider and the health insurance side of things. And so that's particularly important from a consumer digital persona. But there's others that are quantified self that really want connected devices and APIs, and they want to see and gather their data. And there are others that just want a human connection. So you're not going to offer them a digital or virtual solution. You're going to offer them an in-person appointment or a touch point with their doctor telephonically. So really distilling down those digital personas is a whole different way to engage from a health perspective. And we've found that that has been a lot more beneficial than simply looking at whether someone is older, young, or sick, or healthy, or high cost or low cost.
That makes perfect sense. Well, we are at time. Kristen, thank you so much for sharing your experience and deep knowledge with us and with our audience today.
Yeah, absolutely. Thank you so much for having me.
Take care. So
Bye.
next up, we have our interactive panel with 5 or 6, I think today, industry-leading experts to talk about the use of AI and advanced data analytics programs to provide more personalized care.
Hello, my name is Chris White, and I am one of the hosts for Parks Associates' new podcast, The Connected Consumer. This podcast is all about Parks Associates' data-driven market insights on emerging consumer technology products and services. It features our talented analyst team and industry leaders who are bringing new and innovative products to market. Throughout this podcast, you'll get an inside look at the latest industry trends focused on the connected consumer, home automation and security, energy management, connected health and independent living, and digital content and video services. In this episode, we will chat about the Zigbee Alliance and CHIP rebranded to CSA and Matter with guest speaker and our very own researcher, Amanda Cohn.
Thank you, Jennifer, and welcome back, everyone. Thank you for joining us for our panel discussion. So we have here with us a really great lineup of panelists that I'm very happy to speak with today. So I'm going to be going through and briefly introducing everyone, and everybody is also going to give a few minutes to talk about themselves and what they do at their companies. So kicking things off is Jeff Cutler, Chief Commercial Officer at Ada Health. Jeff, can you tell us a little bit about yourself and what you do?
Sure. Thank you, Kristen. For those of you that are unfamiliar with us, Ada is a global health company that was founded to improve human health by transforming knowledge into better outcomes. Our vision, quite simply, is to democratize access to healthcare across the globe and to improve the health of 1 billion people with the trusted medical guidance that we can offer that becomes relevant, actionable, and effective. The company was founded about 11 years ago, and for most of the last 11 years, we've had over 200 people, including about 50 to 60 full-time medical doctors, building what we believe is the world's most advanced knowledge base. And we have 2 lines of business that have come off of it. One is our consumer business, in which we've released the Ada Health app almost 5 years ago, and it's become the #1 medical app in over 150 countries with 11 million users. And on the enterprise side, we're acting as the digital front door for patient access, symptom assessment, and care navigation for a number of global partners, including here in the U.S., both Sutter Health and Kaiser Permanente.
Very interesting. Thank you, Jeff. Next, we have Carrie Hawley, who is the Senior Vice President and Technology Fellow at Optum. Carrie, tell us a little bit about yourself and what you do.
Yes, thanks for the introduction there. Carrie Hawley, I have a unique role at United Health Group Optum, which is that of a technology fellow. And a lot of my focus is on helping the organization advance our capabilities in AI. And so that covers the range from what we do in the cloud, what we do on-prem, and of course, the various healthcare use cases, many of which you see illustrated in terms of how do we actually make patients more healthy? How do we not just do diagnostics with machine learning, but how do we actually influence behavior with respect to lifestyle? How do we make healthcare more affordable to the underserved and others? And of course, how do we reduce costs, and how do we stop physician burnout? So we're not only using AI, but also a lot of complementary technologies like graph, like ambient computing, and other technologies to sort of attack this wide landscape. And my role is really that of technical leader, advisor, consultant, and so forth.
Thank you, Carrie. Sounds like a very interesting perspective and a very wide stack of solutions. So next up, we have Karen Holzberger, who is SVP and GM of Diagnostics at Nuance.
Hi, Kristen. Thanks for having us. Really excited to be a part of this panel. I, again, with Nuance Healthcare, we are a company that uses AI technologies to help the doctors make better intelligent decisions through speech, natural language processing, and other AI tools and technologies to really help them with their day to better do what they do best, is serve their patients.
Thank you, Karen. Very much looking forward to hearing more during our panel. So next we have Dr. Stephen LeBeouf, who is president and co-founder of Valensol. Stephen, or do you prefer Dr. LeBeouf?
I just go by my last name, LeBeouf. Just think I've had enough of LeBeouf. So my name is Dr. Stephen LeBeouf, and I'm the president and also one of the founders of Valensol. And Valensol is an interesting company in this space because, we don't make our own medical devices directly ourselves. At least today we don't. We provide core technology that goes into wearable devices, both on the consumer side for sports and fitness performance and wellness, but also now increasingly more on the medical side. And we provide core technology that allows you to accurately measure heart rate, respiration rate, a variety of biometrics. And now another innovation of ours more recently is blood pressure. And so we provide that to the marketplace and make sure those technologies work so that their use cases can be implemented the right way.
Thank you, LeBeouf. And definitely a lot of very interesting names up here, very interesting solutions being powered by your technology. So looking forward to hearing what you have to say.
All right.
So next, Dr. Stephen Schwalter, who is the Chief Product Officer at Javion.
Hi, Kristen. Thank you for the introduction. I'm an internal medicine physician by background. I joined Javion about 4.5 years ago. The company has been around for about 10 years working on clinical artificial intelligence, really taking the journey from predictive intelligence to prescriptive intelligence, giving insight onto, who really needs an intervention, what that best intervention is, and then how to engage an individual in actually achieving that intervention.
Thank you so much, John. Definitely looking forward to hearing more. And then next and last, we have Jadav Thakkar, who is COO of BioPharmis. Jadav, tell us a little bit about yourself and what you do.
Thank you, Kristen. Hello, everyone. I'm Jadav Thakkar, Chief Operating Officer of BioPharmis. Let me start with a quick note of thank you to Kristen and Park Associates for hosting this very timely and relevant discussion and inviting me to join this panel with thought leaders that I see really shaping the future of healthcare. A little bit about BioPharmis. It was founded in 2015 with a focus on developing predictive analytics for improving health outcome. We provide an end-to-end platform for managing patients at home across the continuum of care. So this includes managing an acute condition to a transitive care, post-acute, post-discharge, and ultimately helping support patient in a chronic condition management. Our major partners and customers have included leading health systems, payers, and pharma companies. Our partnership with pharma company typically involves co-developing combo therapies that combine pharmacotherapy with digital therapy and algorithms. As the slide briefly outlines, the platform includes 3 major pillars. On the left, you see the wearable sensors and actively collected data in terms of symptoms. We are a device agnostic platform, so we include about 50 to 60 devices that we've already integrated to make sure that the right patient gets the right device. Our second and the major pillar includes the FDA-approved SAMDs, algorithms that we have generated clinical evidence for and taken through the FDA's approval process. And the third piece is where this all comes together for a clinician, where the data, as the previous speakers have mentioned, it's quite burdensome to have this high volume data thrown at a clinician. So actionable insight integrated into the EHR is where our third pillar really shines. Often the healthcare industry is really criticized to move slow, but looking back in the last few years, I think the industry has made really good progress, and it's a timely discussion to see where we can take it forward.
thank you, Jadav. Very, very happy to have you here as well.
My pleasure.
Yes, so let's actually just dive right into it and get started. So my question posed to you all today is really, what is AI and personalized medicine, and how is it really being applied today? And then LaBeouf, maybe you can start us off.
Well, at Valence Cell, we see AI every which way from Sunday because of our unique position in the marketplace. We see it all the way from the bottom going up. For example, many of our biometrics, maybe even all of them today, employ AI to generate the biometrics. This is because you don't know for certain maybe what a heart rate is or breathing rate is when there's so much noise that's around. And so AI is used to kind of fill in those gaps. But also our technology that generates blood pressure from these wearable devices, that technology is AI based. It's a machine learning algorithm that converts the optical information from the body into an assessment, an accurate assessment of blood pressure. So AI is right there from the start, but then our customers who put our technology into their products, they have their own AI. For example, one of our customers, they use our technology, our metrics, which are powered by various different machine learning algorithms to guess and estimate whether or not you might be about to wet the bed, for example. Another one of our customers is using our blood pressure technology, or at least evaluating it for the purpose of better understanding sleep health. So they make their own assessments using AI based off the metrics that we provide them that have some AI base around them. And then more broadly, those platforms are going into systems that may make even more sweeping conclusions or estimations based off AI. For example, is this person have a high risk of high mortality? Or is this person maybe at a high risk of where they maybe should have an intervention early on based off of all these assessments that our partners provide? So we see it all across the board.
Certainly many different types of use cases and applications there. And then does anyone else want to share, maybe Jeff?
Sure.
Go ahead, Jadav.
I was just going to add, I think LaBeouf covered some of the key use cases that are certainly there. In other ways, I'll extend upon that is where we work with health systems in a variety of the acute to post-acute condition. So finding out which patient is ready for the discharge, which patient can be managed at their home. And very frequently, that data collected through sensors and wearable need to be converted into that insight that guides the right selection of the patient, the time when they can be discharged, and when they need to be brought back through those AI alerts. So being able to make those decisions with the AI tool is really empowering clinicians to make some of these decisions. On our pharma side, I'll give just an entirely different lens. They are really applying AI tools to look at how they can advance therapy development at a faster rate. Could you pick up a signal on safety and efficacy through the use of AI tool and high volume data that tells something unique about that particular drug? So the overall use cases are quite wide in personalizing treatment through timing the intervention, timing the dose, or even selecting the right dose.
Kristen, if I could just jump in, from our perspective, artificial intelligence, or AI, is quite simply the use of very powerful technology, computing power, against massive amounts of data in order to solve problems. So in our case, there's three components to it, the AI platform. There's the medical knowledge base, which contains all of the world's credible information as it relates to symptoms and the conditions that can be causing them with other findings. And then the AI component is a probabilistic reasoning engine that continually goes against the knowledge base based on every piece of information. So just like a human being, it's reprocessing the entire case with every single piece of data it gets. And that's important because many of the platforms that are out today kind of purport to be AI, but they're really static decision trees, where once you're out on, for instance, the headache or nausea branch of a tree, the questions are all predetermined. And that's just not the way a clinician operates. They draw on the full collective of their wisdom in order to continually decide what might be at play. So that's what AI means to us.
Yeah, I mean, definitely as a physician, the signal's what matters, right? The actual insight is what truly matters. What is AI is a little smudgy, but I don't think what the signal is so smudgy. And the personalization really is about getting a signal strong enough to know what that individual needs, and understand what's going on with that individual's, biometrics, getting those correct, adjusting to, even, can you measure a cachectic, overly malnourished patient's blood pressure just as well as you can measure an obese patient's blood pressure or heart rate with the same biometric tool. So getting that signal by using the right technology, the right math, and getting that to the clinicians in a way that they can act, that's really how we view the personalization side of things. And I think I may have stepped on Karen. I'm sorry.
Yes, I think Karen, you had your hand up earlier.
Sorry, I was just going to comment that I agree with every thing that's been said. I guess I'd add a couple of things. The quest to understand and define AI is an interesting one because its utility, of course, is more important. But I would offer that there's a lot of conversation that equates AI and machine learning, which are not the same. But AI is clearly is aspirational. It clearly is a field of computer science. It clearly involves computing power. And I apologize for my background noise, but hopefully you can still hear me okay. But I guess a couple of things. One is I think that when we talk about personalized medicine, another name for that is precision medicine. And of course, that involves data, massive amounts of data. Of course, it involves a strong signal. But we have to find a way to make sense of those signals. What makes it strong is, of course, its accuracy for that individual, because each individual is different. And this is where artificial intelligence, clearly when we get to more causation, we get to more probabilistic AI, these are all good advances. But I just wanted to emphasize that we're on a journey here. We've been looking at things like a digital twin to do more focus on precision medicine, more personalized medicine, so people can have maybe something in their pocketbook or their purse or whatever that gives them a reflection of their health state at any point in time, not just predictions, but actually probabilities of where they will potentially get a certain disease state, or whether their diet and exercise and movement, et cetera, is having an effect on X, Y, or Z. So just wanted to offer that perspective.
Hey, Carrie, when you talk about making a digital twin, I've always wanted to have a digital twin. Can you make mine evil?
Oh, no.
What if I'm the evil twin?
I think that's probably the more realistic scenario, that the human who has autonomy is going to make that twin evil.
To kind of bring it back, I think there's a couple of key aspects that haven't been touched upon as we talk about precision medicine, personalized medicine, the use of AI, machine learning tools. Is for the doctors, it needs to be within their workflow seamlessly. They're already reaching levels of burnout pre-COVID to now levels that are just almost unsustainable, and they're not doing what they went to school for, is the practice of medicine to improve a patient's outcome. And so as we think about these machine learning tools, the low-hanging fruit, about how do you insert real-time intelligence through did you remember to talk about this in the note? Did you remember to, in the case of a radiologist, put in breast density? These smaller things to actually improve the quality of the documentation so you can improve the patient's care pathway, ultimately improving the patient's outcome. And secondarily, that's important, and to your point, Jeff, very much so, is the doctor is thinking continuously about how to care for that patient. How do you insert feedback loops back to AI on that test set and those continuing training sets so that AI starts to improve and it isn't as, I'll say, what's the right word? It improves over its time on its accuracy, its consistency. Those are also important things to get AI into action, because we've been talking about AI and how it can help us. But what we haven't continued to prove is the positive proof points of today for the doctor to actually improve that patient's life, patient's expectancy, reducing costs of what that is, because you're treating earlier, because AI helps with that. And I think those are important aspects as we start thinking about personalized medicine.
Yeah, I just wanted to echo what you just said, Karen. I think those were some powerful messages, because one of the things we're also focused on is making technology invisible, so that clinicians actually, we've been for decades making technology irresistible, but if we can actually make it invisible, we actually have an opportunity to do what you just said, which is to minimize physician burnout, make the technology seamless, contextual, and impactful to the clinician, so they spend less time with the technology and more time with the patients. So I just wanted to double down on what you said. I think that was outstanding.
Thank you.
Yes. Oh, Jeff, I think you had a.
Yeah, I was just going to add to what Karen and Carrie said, but absolutely, the feedback loop is critical. What we're doing is three things. One, just to alert everyone, we have been appointed by the World Health Organization as the topic driver for their AI work group, and we work with folks on a global basis and competitors and others to establish benchmarks and standards and guidance. The World Health Organization just published their kind of first standards around that in the last couple of days. So that's one thing we do. Secondly, we've started a whole research division, and we're trying to work with the industry to produce research to validate the outcomes, the efficacy, the safety, and even the ultimate recommendations. And then in the product itself, right to Karen's point, we've had to build a feedback loop so that the clinicians themselves can tell us afterwards, was the information helpful, correct? Did it help them determine the right diagnosis? And most importantly, was the triage advice safe? So we try to build that all in, and then the algorithms can improve themselves over time based on that.
Okay. And then, so speaking about the importance of feedback and the importance of maybe new forms of guidance and best practices, can we maybe talk to some of the challenges that companies face in getting these types of solutions, AI and machine learning, approved and actually implemented? So what is the regulatory path to market for some of these AI solutions that may be classified as software as medical devices? And then maybe Jada, can you kick us off? Oh, Jada, is your connection working?
You want me to take a crack at that, Kristen?
Yes, go ahead.
Okay. So so Nuance spends in the healthcare business, we do much work with the radiologist who is using AI from.
Certainly. Let me make sure. Are you guys able to hear me okay? There was a little bit of breakup for me.
Oh, I think there may be a little bit of a delay in the connections. I think Karen began kicking us off, but we could start with one and switch to the other.
Jada, why don't you start? Okay.
Yeah. Well, I was just confirming. Are you guys able to hear me?
Yes, we can hear you. Your picture's not moving, so there might be a slight connection issue.
You really stopped at a great spot, though. It's a beautiful smile.
Okay, actually, Karen, why don't you continue while we try to figure out what's going on?
Perfect. Yeah, sure. And others, please jump in, because I'm going to now come from a radiologist point of view, who's really the doctor's doctor, to the primary care team. With AI, when they're identifying the pixels, doing quantification or diagnostics, those are regulated medical devices, which we're really grappling with about when it becomes aided diagnosis versus triaging or prioritizing, and the doctor's making the diagnostic decision, is part of the regulatory hurdles that we're facing today. I do think we've been a bit short-sighted in the industry, where there is other AI for the doctor using natural language processing to do clinical recommendations, standardizing recommendations after what the radiologist calls as an impression. They're describing what they see in the patient's images and what that follow-up care is for the doctor. I think there are these two places that we can put real emphasis on about this real-time intelligence through clinical recommendations and follow-up, versus spending all our time on diagnosing the pixels or the DICOM images or the CT images, if you're not so familiar with radiology or enterprise imaging, to be able to do that. But there is this interest criteria with our federal government through the FDA to have these tools, certified for their safety and efficacy. And it's something, if you're an AI vendor who's out there with a lot of X-ray data or CT data, lung data, and are trying to build these algorithms, because there's certainly millions and millions and millions of images out there to build algorithms, machine learning algorithms off of, understanding what it takes to do that. And then secondarily, what does it take to put it into workflow for the radiologist so it doesn't slow them down? I think those are the two key areas to really be thinking about as you're taking an algorithm to market.
Mm-hmm.
Jada, do you have something also to add? Because I know you're talking from another side of medical device.
Oh, yes, thank you. My apologies for that internet connection. So yes, what we end up doing is take an algorithm that starts with how would you take a typical medical device, collect the data, you have to train the algorithm on significant amount of data, take it to the next stage, and then generate the validation in the clinical trial phase. We've been very fortunate to work very closely with regulators like FDA, and I can tell you that over the few years, FDA have been very, very receptive. What was seen as a regulatory barrier, they're quite welcoming, working with leading companies and in shaping both the guidance as well as how we can get these pathways through. So we've been fortunate to leverage that partnership and get a couple of algorithms that have gone through that entire clearance process through FDA.
Another interesting perspective, I'm sorry, Carrie, is around clinical trials for either medical devices to actually bring drugs and different pharmaceuticals or medical devices earlier to market by using AI in the research, in the clinical trials to actually build those packages together for the FDA. And that's another, I think, JD, that you were talking about, and maybe Carrie, you're going to touch on too.
Actually, I wasn't going to touch on that, but I just wanted to comment on I sort of saw the question as two-part, and all of you guys have a lot more knowledge than I on medical devices and regulatory, but you also asked the question about adoption and how do we get the enterprise more effective, efficient in terms of AI. And I just wanted to make a brief comment that that's a big challenge, that these large organizations, I work at one, of course, right now with UHG and Optum, and we rely heavily on the tech companies and the cloud services, the democratization that's occurring around AI, the work that folks like that you guys are doing at Nuance and Microsoft and Ada, all the work that the startups and non-startups are doing. We rely heavily on those on your organizations to advance the work we do in AI. I just wanted to emphasize that.
And Kristen, just wanted to quickly add on the medical device regulation side. We are subject to MDR in Europe. As a quick update, it was supposed to be enacted about a year ago. I think it was last end of May or June, but it was postponed for a year in COVID. It is now out there. We've structured the company around it. And what we're going to find is the FDA, as previously mentioned, is not currently enforcing at least software platforms like ours, but they've indicated that they will do so at their own discretion. But they've also indicated that they're going to follow Europe's lead when they do ultimately regulate platforms like ours. And what we've learned is, to Karen and others' points, you've really got to focus on the clinical research, the data, and then very importantly, the post-market surveillance. And one of the things that a lot of our partners in the industry are going to learn is once something's declared a medical device, it can't be white labeled. And we deal with that a lot because a lot of health systems are white labeling platforms like ours right now, but they're going to find once the FDA enforces medical device regulation that it's quite possible that if they don't adopt the approved device's brand, that they may be subject to the burden of the regulation themselves. So it's going to be a lot of fun times and changes in the next year, I think we can say.
Yeah, certainly sounds like a very big learning curve for many companies. And were there, I guess, any other thoughts on this, or we could jump ahead?
Well, one thing I would say is from ValenCell's perspective in this case, we are pursuing FDA approval for our blood pressure technology, which gives an accurate assessment of blood pressure with these wearable devices, with the optical sensor data that comes out of these devices. And it's based around this layer of machine learning. And the thing about that should be concerning, people should consider anytime something like this is proposed is if I'm going to directly measure pressure, I have a sensor that's very linear. I apply a force to it. I see what the pressure result is. In ValenCell's case, we've got this model that connects the dots between this blood flow information we collect from light to blood pressure. It's very nonlinear. And so from the FDA's perspective, you got this black box that's doing all these brain-like calculations that you can't peer into, and you shouldn't be able to peer into because of the proprietary technology, but you want to make sure it's thinking correctly. So one of the things we've had to do is explain at least enough how it fundamentally works so that people can understand where and better appreciate where the risk might be when it generates a value. So you can't just have a black box. You do have to do enough explanation for people to understand what could go wrong with those assessments.
Yes, so certainly it's a big change from maybe some of the earlier models of data science where you had algorithms that were applied that may have been complicated, but they were also understandable by humans.
Yeah, and I think it's important to note that, and I don't think we're ever going to, well, not ever, but, in the near term, not going to be, comfortable with purely black box. Software as a medical device is going to have to be, explainable beyond, oh, there's some hidden layers and we got some accuracy in order for it to move forward as a medical device. The same is true on the clinical decision support software. At that side, you really have to be able to explain it. You have to be able to make it clear to the clinicians, how those decisions were made. And if you're using advanced, artificial intelligence techniques, you're going to have to figure out how you unravel those techniques to explain it to the clinicians. The clinical decision support as a software level is continuing to rise. And probably will slowly fade away as the FDA gets into regulating it. But it's definitely the black box era is probably over, and the technologies that are able to successfully identify that signal and explain how they define that signal are going to have a distinctive edge.
I like living on the edge, so that works well for me.
I think it is worth noting that this is where starting early, if you can start in the clinical trial phase, you've got so much opportunity there. You're doing it under an IRB reviewed protocol. There is an additional oversight. Getting your algorithm through that research phase, work with the pharma company, just offer them as an additional tool. While you do have an additional mitigation, you're not just relying upon an algorithm. Your rest of the standard procedures are still there, but you are able to collect the data and generate that evidence that not only regulators, but also makes clinicians comfortable when you get there. I would say there are some algorithms that the power of the machine is you can't comprehend it. It's not going to be white box. So black box algorithm do have a significant value. Collecting the proper research data and evidence is how we might be able to get them through and get everyone to feel comfortable about them.
Yeah, just very quickly, John, I think it was, made a wonderful point on that, and that is something that everyone needs to consider. I mean, this whole world of software as a medical device for patients is one thing, but as John said, once you get into that clinical decision support stuff, it takes on a whole other level. And what we're finding, to his point, is as long as you let them know, what went into the algorithm, the decision, and you're not making the decision for them, it won't be subject to the clinical support regulation. So as an example, we'll provide the full patient dialogue, we'll provide the differential diagnoses and the associated probabilities, but then kind of hand that to the clinician and say, now you use this data and your collective wisdom to make the decision. We're not going to make it for you. And that's a big difference.
And that's very important about inserting the real-time intelligence, the decision support tools at that point to let them ultimately the decision, like, no, I've got enough other information that I'm going to disregard this, or this is a great reminder for me. We all use Grammarly, and I think Grammarly works so well because of the way they've done the workflow for us as we think about how we write. And this is how decision support tools have to work in the electronic health record, in the creation of the documents, in the creation of the ordering process, whatever it is, to get to, patients are becoming more and more informed consumers. And so whether it's about where am I going to go to the highest quality, most cost-effective provider, whether it's, for imaging, whether it's for my PCP, how is AI going to be able to help the doctor say, like, look, I've got a more informed care pathway. So all those pieces that they can still be doctors is really, I think, at the end game for all of us as being part of the industry.
Yeah, I just wanted to comment. I think Jeff and Karen, you make some outstanding points. I think, Jeff, the point you made about autonomy, I think is really key because, giving systems software autonomy is a different issue than explainability and black box. And then Karen, you brought up the Grammarly, because I think clinicians, and John, you keep me honest here, but I think clinicians use black boxes all the time. The stethoscope is a black box and you trust it. And the duality of software and the state of software and AI today arguably doesn't give you that same level of trust, but we'll get there. as we do more with explainability and so forth. So I just wanted to put sort of a futuristic view out there in terms of where we're going.
No, that was really well said. Trust is so important for software, tools, technology, and for sure AI. That was, yeah.
I'll give you another example in blood pressure, and this is, I mean, really apropos for what I do in the field is, when oscillometric blood pressure monitors were first developed a few decades ago, it was a long time before physicians ever trusted those, and it wasn't because oscillometric blood pressure monitors didn't work; they worked beautifully. It took a while to trust. I mean, what am I going to trust? My ears more or this oscillometric cuff? And I'm taking a measurement, and maybe this measurement I took with my traditional sculptatory methodology got a certain blood pressure in the oscillometric cuff, and that a few minutes later measured 10 millimeters of mercury different. And now I have this distrust, and it took a long amount of time for people to really feel like, yeah, this really is getting me what I need in a more effective way. And for valence cells technology and wearable devices, there'll be something similar to that, and it should be. There should be this appreciation of trust that you have to earn to get to that point.
Yeah, no, we like to convince ourselves that, as physicians, that we actually completely understand the stethoscope. But, we don't really, right? I mean, like, go ahead and ask them to explain the physics of the sound waves and, how the heart, pumping moves the skin, moves the diaphragm, and then, but we convince ourselves that we understand enough of acoustics that we understand the stethoscope, right? But we really don't. We trust it. And I do think we're going to get there with software, and we've got example after example in healthcare around our adoption of innovation. That it's until we trust it, and then once it's trusted, it's rapidly adopted. But that until they trust it phase can vary a lot.
Yep.
Okay, so something else that I think we're all very interested in is, so we talked about this a little bit earlier today with Christian Valdez's very interesting executive Q&A. So with EHR integration largely considered table stakes today, the ability for services and solutions to integrate with clinical workflows have really become key. When it comes to this type of integration, what do you believe are the current greatest challenges, and how are these challenges really being addressed?
I'll just pipe in because you guys will have a more complete answer. But Karen talked about physician burnout, and I think that a lot of solutions, and particularly AI solutions, don't accommodate change management. And really, I mean, doctors, at my current company remind me of this often, that technology. In fact, one doctor, Vern Smith, just flatly said, technology has never helped me with a patient. Maybe that's an overstatement, but the point he was making is that when he's working with the patient one-on-one, it's not technology that provides the assistance to him. And I think that to answer your question, we have to be cautious of, and Karen and others have spoke to this, we have to be very careful as we introduce technology that we're not enhancing, facilitating, accelerating physician burnout, that we're actually doing good. And I think there's a big challenge there.
Yeah,
and I think, yeah,
I'm sorry,
go
go
ahead.
on, Carrie. No,
No,
Carrie,
go ahead,
you
Karen.
continue. No, exactly that. The adoption of electronic health records, of collecting that data, very important milestone for us is in the US and what is happening now globally in Europe with the adoption of electronic health records. But we jam technology now, a computer between the patient and the doctor. I see it all the time with my pediatrician for my girls. And what do we have to do to take technologies, even if it's speech, to capture that conversation, to put it into the document, that conversation between the patient and the doctor? Because now we're inserting up another person in the middle of it to capture that conversation, to put it in the structured way so you get reimbursed. That has to stop, Carrie, to your point. And like, what can AI do there to capture that conversation, capture that document, so you're getting the right reimbursement back to the health system, back to them, so they're not doing the documentation at night. I have similar stories with doctors that sit on staff here at Nuance. Like, I repeat my day every night. I see my patients all throughout the day, and then I repeat my night when I have to do all the documentation, electronic health record. And this is a perfect example of AI where it's not going to be regulated the same way like we see with medical devices or therapies and that sort of thing, but very small things to help create the documents, stop the burnout, get accurate information back to the patient so they also understand. So exactly what you're saying, Carrie.
Yeah, I was going to say, I think one of the biggest problems is the myth that the EHR is a clinical workflow. So integrating with an EHR is table stakes, but it's not a clinical workflow. I have to log into it. I have to check it. If you're working with somebody like Ada and someone has an interaction and I need an alert, dropping that into my inbox in the EHR, I might check it next week. I might check it in the morning. I'm certainly not going to interact with it in real time and be like, oh, I really need to deal with this right now. So although it's table stakes and to have that integration, it certainly is not a great clinical workflow for probably the majority of things that we really need to accomplish to reduce burnout, to improve patient outcomes, to deal with the volume of information we're having today. Just putting more of it into a clinician's inbox or to have it as an alert if I happen to open the chart, is not what we need to tackle in order to move things forward.
No, I'll fully echo that. And we did an implementation with one of the large health systems. The very first question was, well, can you integrate your alerts and your dashboard into the EHR? Can we just use the alerts that are in our EHR? So sure, we do that integration. Karen mentioned over FHIR. We completed that integration. And the next thing we know is, well, there are hundreds of alerts that EHR is generating. That's just completely useless in burnout because of all the false positive. And the EHRs are designed for looking at each parameter separately. A heart rate is looked at, activity is looked at. They're not capable of handling all these multiple parameters, which today's AI tools are really driven towards. So the next thing we did was, well, we will keep that single sign-on. We'll keep that functionality where you can launch to our dashboard from your EHR. But the sophistication that our dashboard provides, it allows you to quickly zoom into what is going on with this patient. That actionable insight was hugely helpful rather than sticking everything in the EHR when it was not really designed to handle complexities that today's AI tools are able to handle.
Yeah, if I could just add to this, it was interesting when we first launched as the front door for Sutter Health in April of 2019. I believe it was within the first 3-4 weeks, they actually got somewhere north of 400 emails from patients using the service asking if they could share the assessment information with their clinician. And to that point, it had been an anonymous experience. And that's when we started working with them on making it truly available to the clinicians to help them. But to John and some of the other points that were made, in the past, at least in my experience, like if you were integrating with an EHR, you would like throw it, as he said, in the inbox, or you would throw it in the media tab of Epic. And we've continually heard from the clinical that that's not their workflow. So what we're trying to do is make it available at that point of care, right at that point where they're seeing the patient, right at that point where they're opening the record, so that data that merges with the historical, the risk factors, the medical history, and it becomes part of the entire picture. And then the last piece relating to the burnout, I've heard from many physicians, a lot of my friends, that in the last couple of years, they've had to add, on average, about 2 hours to the end of their day just to document all the cases they saw that day. So as we look at that, if we can make that easier and actually allow them to take the data that the patient reported and put that into the EHR without them having to manually type it again, then we hope that we can address some of the burnout and make them actually more productive.
And there are tools starting to emerge in the industry to exactly help with that, the low-hanging fruit of the documentation. So you're not now inserting a medical scribe, but how can you use AI to capture that ambient conversation between patient and doctor and understand the different voices and the different gestures through those types of vision and machine learning.
Also, I'll just throw in, very frequently we think about what the clinician might benefit from. And there are clinicians on these panels, I'll probably draw their attention that often it's include them in the making of your solution. Don't assume what you need. For us, we were very fortunate folks like Brigham's leading physicians, Mayo Clinic, and them partnering with us in what they wanted. What happens when they want to delegate an alert to the nurse, or nurse needs an app versus a web screen? What the clinicians can tell is so valuable. So include them in your, not just assume what they might think usable.
Deb, I think the connection might have dropped again.
Oh, sorry. I was just going to say, let me pass back to include the clinicians in your design making process.
Yes.
Make sure that their input is first.
Yes, here. You can't. Engineers make the worst doctors.
Yes. It looks like he might have dropped off again, so we're going to try to reestablish that.
So it goes the other way as well. Doctors don't make the best engineers per se.
Right, look at that. See, that's why engineers are developers are developers, and doctors do what doctors do. Exactly.
Doctors are educated to recognize the exception and manage the exception.
Yes.
Engineers want the whole process to work by the whole process. Having done engineering school and then gone to med school, there's a distinct difference in that approach. And after finishing the residency training, I'm not as good as an engineer as I was before I started.
Well, that's how it goes sometimes.
I was just going to add one of the questions, part of the prior question about how do you increase adoption. One of the things that we have found is we need to really work across the silos, the departments of the health system. So if we don't involve the innovation team, the clinical team, the executive team, and the product team, at some point there's going to be a blocker. The clinical team feels that the digital or the innovation team are forcing solutions to them. Likewise, the digital team or the engineering team doesn't think that they understand some of the engineering problems they're dealing with. So we've really found that we've got to get them all at the table and understanding and answering all of their questions, usually in one single meeting, to get the buy-in across the organization.
So it looks like J-Dev is trying to make it back. I'll give him maybe a few more seconds to see if he can pop back in and kind of finish his train of thought, or we could go into the next question now. I want to make sure I leave enough time for questions from the audience.
No worries, Kristen. Why don't you go ahead? I'm listening, and then maybe I'll request to turn on the camera too. But please go ahead.
Okay. It's technology. It is kind of funny on a panel talking about technology, but I guess we all know what it's like. So let's jump into the next question, which kind of goes back around to some of our discussions before about software as medical devices. So one of the big challenges in terms of getting health tech adopted is really building up sufficient clinical evidence of effectiveness and tying that back to a strong business case. 2020 took remote patient monitoring and virtual care from pilot projects to major rollouts in many cases. But as of right now, it seems like a lot of that effort was focused on the low-hanging fruit. Really, what would you say is next from here?
Well, this question really resonates with me because I have the saying that goes, chemistry can be instantaneous, but biology takes time. And this is broadly across the case of just developing new biometrics with wearable devices, which we do, but then also in proving out the validation that these will improve outcomes and then also reduce costs, because everything that comes across my desk on any medical device, any medical solution we get involved in, one common theme is you've got to improve outcomes that reduce cost. Those two are tied together because everything costs too much and everyone wants a better outcome. And so taking the technology to cross all those levels is what we deal with all the time at Valence Cell.
Dr. LeBouf, you just defined value-based care. Perfect. I mean, increasing quality, reducing costs. Absolutely, that's what AI has to start proving. And that goes to Carrie's point about trust and adoption and getting this to scale. I mean, just well said.
Also feel sorry, go ahead.
Oh, I was going to say, actually building on what Jared has said before, I mean, we need to plan early to prove our evidence. We just today found out, that one of our peer-reviewed journal articles went live online today, around our ability to predict mortality oncology patients. that's been a 3-year journey. I mean, from designing the study to running the study to collecting all of the outcomes data, for a year follow-up on mortality to then going through all the hoops to get it published. If you decide to start thinking about the research, the publication, the proof points at the end, you're really far behind the 8 ball. So if you're out there working on, AI, then you should be designing these studies up on the front end, working through the IRB determinations and knowing what you're going after from the get-go. And you should be looking at that from your partners. Are you actually doing those processes? Because if they're not, they're definitely not as forward thinking as they need to be, especially with the regulations that we are expecting to see come down from the FDA.
Now, I'll tell you one thing that comes to mind right now on this is because of COVID and because of how COVID kind of accelerated the adoption of remote patient monitoring, a lot of these technologies and platforms that had been around for a while were suddenly more widely adopted, and that's going to help a lot because the fact that the platforms exist now and are used more to be able to implement these new innovations is going to help out a lot. I mean, when ValenCell started in 2006, these platforms just did not exist at the scale that they do today. And so if we had a solution that could be very useful and maybe improve outcomes and reduce costs, what platform would we stick it into? So I do think that benefit will help. I guess maybe it's a little more optimism and intuitive than anything else. I do think the fact that these platforms are being more widely adopted and respected and trusted is going to help accelerate some of these use cases really being implemented and having the real outcome of improving outcomes at reduced cost.
Yeah, I'll just weigh in quickly. And I think to the point of your question, Kristen, it is all about kind of building up that clinical evidence, the research. And as a result, we've had to just set up an entire clinical research team, and we have a whole page on our website with the studies. But we've also found that if we can get our partners focused on doing the research themselves, that's even better, because then it's more independent. They get excited, they buy in. So as an example, when we first launched, there was a lot of questions in the industry with platforms like ours: are they as accurate as a nurse triage line? And is it just going to appeal to the younger demographic? So to that point, Stanford University and Sutter Health worked together almost in a year in analyzing every single assessment that we did for them, and produced a study that showed that it was akin and equivalent to the same advice that a nurse would give, and it's the same demographics across their system. We've been working with a number of doctors, for instance, to prove clinical evidence. And one of the things we did to one of the earlier points is one of our competitors is out there for the last few years claiming that they're going to replace doctors, which is obviously received very offensively. We put out a study that measured doctors' accuracy. We showed that it was obviously better than ours, but we also showed that when we put our assessment in their hands, we doubled their accuracy. So it's trying to do things like that to prove the evidence, prove how it's going to help them, and really move it forward. And I think the last piece, as Karen alluded to, was just measuring the value. In cases like ours, and I'll use Sutter once again as an example, we do about 4,000 assessments a month, consistently every month across their 3.3 million patients. About 48% of them are off hours, and 42% are directing them away from same-day urgent care. So if you do the math, that's over 1,000 people a month that we're redirecting away from unnecessary expensive services like emergency rooms or urgent cares. You take the average numbers from CMS of $1,700 or $1,800 per visit, and that in itself is $1.5 to $2 million of value that we could be potentially driving each month. But the challenge is now, how do you measure that? How do you prove that? And how do you work with your clients so that they can understand that and value it even more?
It sounds like it's also absolutely a matter of what kind of business models they have implemented.
I was going to add,
it's funny you say that, because being fee for service, in the first couple of weeks when we saw the number of people we were redirecting away from the ER, we called Sutter's executives to let them know, because we were worried that there might be someone with revenue responsibility that was kind of questioning what was happening. And to their point, we're all moving to population health and value-based care, and this is the way we've got to go in order to treat people better and more economically.
Right. The service lines can't be thinking about the revenue that they're generating as part of the health system. It has to be about improvement of the patient's treatment plan as a whole, about, okay, maybe you're going to identify cancer more quickly through follow-up care and standardized follow-ups when that patient's coming through the ER through an incidental finding. How do you use AI to present the right surgical, maybe there's potential surgery for a rare disease like CTEPH, for those types of things, that it's the entire patient care pathway that has to be looked at across the life of the patient and where they are in the health system, not the parts of what the ER is doing versus imaging is doing versus, intensive care, like all those different service lines that you have to have them come together about what's going to be best for the patient at that time.
Yeah, I was going to add that aside from improving overall outcome, one thing we probably should focus on, and hopefully that goes there, is bring the patient back in the focus, right? Part of this conversation is how is patient benefiting from it, and then how can we advance the care from the patient's lens? And part of what we have frequently found in our feedback and surveys is that, and in COVID, to a large extent, helped us understand that four walls of a hospital or clinician's office isn't the best location every single time for patient to receive the care. So can we create an environment that is safe, effective, to let the patient receive the care where it is optimal? And in many cases, it's at their home. So having the technology be an assistive, certainly not replace, but assist the clinician so that patient can receive the care in the comfort of their home, potentially safer, in many cases recovering much faster. It does
And
result,
more cost effectively too.
I was going to say, it results in cost effective too, precisely. So you start with patient, help them receive the care, and you will end up getting cost effective solutions as well.
Very much so.
Okay, it looks like we have a few more minutes left, and I would like to make sure we address at least a few questions from our audience. So we have an audience member who is interested in learning who exactly is the most likely recipient of monitored device data and resulting insights, the patient, the local physician, a telehealth service, or other.
So in our implementations, typically what we do is we have a clinical command center that monitors this first set of data. They do the initial triaging and alerting, and then escalate to the treating physician of that patient. Sending it directly to the patient, I think it's a bit premature, given that a lot of the species are still getting mature, and it will just concern the patient. So that's typically an optimal path we have seen.
Okay, so yes, it's a lot of times hospitals and health centers, they don't have the ability to take in that fire hose of data and actually make sense of it. So they're working with partners. Okay. So yes, we have another question here. So it looks like they're asking how big of an issue data integration is. Will privacy and security continue to be huge barriers for consumers?
I'll just jump in. Integration, I think my colleagues would agree, continues to be a huge issue, and interoperability. So it's not a problem I think we've solved. Regulatory concerns, privacy concerns, and I do think the need to protect privacy is paramount, which is maybe, I don't know, a tailwind, headwind on this whole issue, but I'll let others comment, but it is a big issue, and I don't see an easy solution in sight. I know with standards like FHIR and others that we're making progress. I know with government regulatory actions on interoperability, we're making progress, but we still got a long way to go.
I would agree. I think with some of the new language in the CARES Act around interoperability is going to continue to open this up. I think you also see patients are open to, having their information shared as long as they're in control of it. I mean, I think we're seeing this generational shift of, I think, what I thought was as PHI as a patient versus, I think, some of the millennials that are very open to different ways of, having their PHI used to have a better healthcare outcome for themselves. It's
I'll tell you, if I see another damn millennials a video of the colonoscopy, I'm gonna go crazy.
Yeah, I know. Or a revaccination card on there, like 10 years ago, like, why are you sharing your birth date? And it's all very free right now. So I think between what the government is doing through the CARES Act around forcing interoperability between these systems to get the values out of electronic health records, the adoptions that we all have to do is standardize around FHIR or these are the things that are going to start to move the needle, as you were saying, both Jaydeep and Carrie, about this, but a long way to go.
Yeah, Karen, I would like to add that most patients actually are quite comfortable to share their data if they are being properly educated during the onboarding process, that this information is not going to be sold. Like Biopharm has made a stand long ago, we will not sell any data ever. The data is only to care for you. We are quite comfortable acknowledging that you can use the data, sure, if it is strictly for me. And then we have to, as an industry, make sure security remains paramount, that inadvertently ever that patient's data is not compromised.
Right, and this is where we started this discussion around personalized medicine.
Yeah.
You have to have data shared and used to have this personalized experience.
And I think you bring up a great point, Jaydeep and Karen and Dr. LeBeouf as well. We're going to see a societal shift with young people. That's number one. But the point that you made, Jaydeep, about because I don't think we're there yet, where people believe that data won't be used against them. Whether it's denying them healthcare services or denying them healthcare. When we get to that level of trust, I think we might see a whole new shift in thinking.
Yeah, one thing I was going to add, just related to the privacy piece, that we are starting to deal with is kind of the intersection of GDPR and HIPAA here in the U.S. And we're taking a forward-looking approach and kind of combining the two, and making sure that we're appealing to both. And a big part of that, as many of my fellow panelists have said, is really being explicit with your consents, how the data is being used. And that is an awakening for some U.S. health systems to realize that we've got to do that. But we do. And then the other piece, as Karen mentioned, is we really are starting to see progress towards this aggregated personal health record. Some of the things that Apple and others are doing, at least for the first time I'm able to see my own personal health record aggregated. And as that becomes reality, we think that, to Karen's point, patients will make that decision and decide who to share their data with. They'll be the owners of the data. And I think we don't need to look any farther than the evolution of the financial services industry in the last 20 years. As people were like hesitant to share any bank account information until they started to realize the benefits of having these aggregated services. Right. I think it's going to be similar.
A great analogy to that, Jeff, is just, I have this application. I want to say it's called CreditWise, where it shows me how much my credit sucks. It explains to me why, and it's so intuitive and so easy to use. In that kind of representation of my health, I would totally dig.
Yeah.
Yeah. That damn evil twin's always spending my money.
It certainly sounds like there is a lot of potential over the coming years, a lot of momentum to back that potential up, but we still have a long ways to go before we manage to actualize it. But yes, thank you all so very much for joining us today. I think it was a wonderful discussion. I was very happy to hear all of the great insights you have. Unfortunately, we are out of time. But we are going to be able to continue at least part of our discussion in the networking rooms that I believe have just been opened up. So you just need to click the link in the chat and you will be directed towards a Zoom chat room where we can all hang out together and discuss some of our findings and maybe follow up further on a few questions. But yes, thank you all so very much for attending our Connected Health Summit today. Very much hoping that you've learned at least something new. But yes, I guess before you head on out, just a quick reminder that we do have quite a few bits of upcoming research coming out of our surveys for this year, as well as some of our industry reports research ongoing, including an industry report I'm working on right now about connected health state of the market, looking at all of the changes that have happened over 2020 and 2021, as well as what we can expect for the future. Again, thank you all so very much for joining us, and a special thank you to our sponsors again, Alarm.com and Everise. I hope to see you all again sometime soon.